landmark studies, we have Dr. Shweta Tripathi.
A very good morning, I can say. A very good morning to all. And at the outset, I would like to thank AIOS for giving me this opportunity. So why the landmark studies are important when it comes to the glaucoma diagnosis? That's because it's all about the decision making, like ocular hypertensives, when to treat, not to treat, or treat them, then as to what are the things which we have to keep in mind. How much IOP? These are the questions which arise when we approach a glaucoma patient. So how much IOP is good for my patient? And is really my patient progressing? And if we have to start a treatment regime for our patient, what would be the best option for the patient? So to address all these questions, there are several studies in the field of primary open angle glaucoma which address the questions and solve the queries to a larger extent. So start with the first ocular hypertension treatment study, which was aimed at two questions. First is that whether the topical medications delays or prevent the glaucoma in ocular hypertension, and second was to identify the risk factors. So with that, the outcome which was monitored after 5 years of follow-up was that 9.5% cases in the observation group and 4.4% cases in the treatment group, they did progress to glaucoma. Now again, there were certain unanswered questions for which OHTS phase 2 had to come up. The unanswered questions were as to if we have to start the treatment, then when should we start the treatment, and if all the OHT cases should receive the early treatment. And to answer all that, the risk factors were outlined, which were the low pachymetry findings, pressures more than 26 millimeters, cup disc ratio more than 0.5, and also the baseline higher pattern standard deviation value. These were supposedly known as the high risk factors. So what do we study from this lesson? What do we infer from this study? That the risk factors should always be considered before starting therapy. There are two things. If there are no risk factors, you can observe the case. If the patient is having any of the risk factors, whether it's a thin cornea, pressures are high, age is little higher side, or the higher PSD, we need to treat the case. Now, again with this study, the role of diurnal variation, the large diurnal variation was emphasized, the study done by Thomas et al. And they said that when we start the patient on OHT, we need to go for a diurnal variation test, and if there is a larger fluctuation, even without the risk factors, we can just give a trial of treatment. So the pearls for the clinician would be that the ocular hypertensive patients at high risk may benefit from close follow-up and early treatment, and the low-risk patients can be monitored with less frequent follow-up and may not need an early treatment. Now coming to the other study, that's early manifest glaucoma trial, which aimed at two things. That for the newly diagnosed POAG cases, whether to start the immediate treatment or can we wait for a while or no treatment. So for this, the exclusion criteria was more important. That was, they did not include the cases who had MD more than 16 decibel, pressures more than 35, and visual acuity less than 20/40. And the endpoint here was to have a progression of field or disc. Now, to summarize, after 6 years of follow-up, they came with the inference that 62% patients in the no treatment group, it progressed. That means a larger amount progressed without the treatment, and the treatment group only 45% progressed. Again, they outlined the baseline risk factors in which, besides the OHTS risk factors, pseudo exfoliation was added, and here they had added that mean deviation should be 4 decibel or worse. So for follow-up visits, they made a guideline that every millimeter reduction of pressure from the baseline reduces the risk of progression by 10%, and disc hemorrhages should be kept in mind when we are monitoring the patient's disease progression. So what do we learn from the EMGT? Treatment is really important when it comes to the purely diagnosed cases. Every millimeter reduction counts, and target IOP needs to be titrated as and when required. It cannot be a single fixed number all the time. Aggressive treatment is definitely required for the patients with high risk factors. And here, again, one more additional pulse for the clinician, that exfoliation syndrome can be considered as an important pressure-independent risk factor for the progression. Now, exfoliation, if it is there, we need to monitor the patient closely and start the treatment again. Now, coming to the third study, that's collaborative initial glaucoma treatment study, where the aim was to compare the effect of medical treatment, that's in the form of topical drugs, or the trabeculectomy on early diagnosed open-angle glaucoma cases, and also the impact of this treatment on the quality of life of the patient. So it was summarized, and it was inferred that in the surgical group, there was increased risk of visual loss initially due to cataracts, if not performed correctly. And by the end of 4 years, both the groups, whether it was a medical group or the surgical group, the quality of life, they showed similar results. Now, even the subgroup analysis showed that that is always a proven fact, that initial surgery has always been a better options for the patients who are having advanced vision loss, because it reduces the IOP fluctuation to a larger extent. These were the factors which affects the outcome, and the lessons learned from this would be that treatment options should always be discussed with your patients, and surgery can be considered as the first option for the advanced diseases. Now, filtering surgeries, they do give better results, we all know that, and minimum fluctuation should be considered. Now, coming to the other study, that's collaborative normal tension glaucoma study. This was really important, as the nature of the normal tension glaucoma is unpredictable. Sometimes it goes very slow, otherwise it can rapid progression. So the aim here was that there is any role of IOP when it comes to the etiopathogenesis of NTG, and to learn about the untreated natural history of the NTGs. The exclusion criteria was really important, because this is the one of the DDs which we make in our clinic when we diagnose a case of NTG. As we say that NTG is a diagnosis of exclusion, so a burnt out glaucoma and a hemodynamic crisis which could affect the optic nerve perfusion was definitely excluded. And the randomization criteria was documented disease progression and a visual field which was threatening the fixation. To summarize, this study stated that lowering the IOP in normal tension glaucoma definitely slowed down the progression, and factors associated with progression, as my previous speakers have been very correctly pointing out, that disc hemorrhage needs to be carefully monitored for migraine and female character. Now, talking about the clinical pearls, which this CNGTS we would like to share with the audience here, would be that we have to distinguish between a progressive and a non-progressive disease. And progression, as I said, that is highly variable in cases of NTG. More than half are slow progresses, but yes, we need to monitor them. But the most important takeaway would be that surgeries may not be necessarily initiated in the early stages. Now, the last would be that the advanced glaucoma intervention study, where the aim was to see the outcome of laser and surgical interventions in the eyes that have failed on medical treatment, and the association between control of IOP after surgical intervention. So to summarize, I can say that in this particular study, the patients were divided into two groups. First, that was subjected to TRAP, then later on to ALT, and then TRAP. That was a TAT group. And the other one was the ATT group, where the patients were subjected first to the ALT treatment. And the results was that in blacks, the vision was better with the ALT first, and in whites, the vision was better with the ALT in the initial 4 years, and better in the surgery group later on. The lessons learned would be that TRAP controls the IOP fluctuation better. The risk was definitely a bit higher. Race should always be considered when we are choosing our therapy, and IOP more than 18 and wide IOP fluctuation means your patient definitely needs treatment. Just a second, I'm just finishing it. So take home with the conclusion would be from different studies. EMGT, we can say that lowering of IOP by every millimeter helps in prevention of progression. AG says that if IOP is maintained in the lower teens, most glaucoma will not progress if other factors are not there. CNGTS says that many cases of NTG, they do not progress. But if they do, the only proven method of treatment is IOP lowering. And last but not the least would be the OHTS, which says that all ocular hypertensives, they do not need treatment. If the clinical decision should be taken for the treatment, the risk factors should always be kept in mind. Thank you very much for your patient hearing.
That was a very good overall overview of all the randomized clinical
Thank you,
trials
ma'am.
and very well brought out how those clinical trials can be actually transferred into your real-time practice.
Thank you, ma'am.
And very, very specific points that you really need to take from each of these studies and apply them to your day-to-day practice. So you are actually able to practice as a much better glaucoma consultant. You do a lot of justice to your patients, and you have not actually, participated in those trials, but you got so much to pick up from those trials.
Thank you very much.
Wonderful presentation. Thank you very much. So
With that,
this,
yes, sir. With that, we conclude this session of Glaucoma 360 with a varied topics ranging from diagnosis to